Good morning. First case is an 84-year-old female, status post MVC with a right distal femur fracture. There's an intra-articular component. She's taken for a distal femur ORIF. Next is a 66-year-old female, status post fall with a right AC separation. 2, just placed in a sling. Next is a 36-year-old male, status post fall with a left proximal humerus fracture. Just placed in a sling.
Morning. First case is a 90-year-old male, status post fall with a right proximal humerus fracture. He was neurovascularly intact, including the axillary nerve, and made non-weight bearing in a sling. Next case is a 64-year-old male, status post MVC, came in as a trauma. Was found to have a small subdural that was stable on repeat CT, as well as a right C1 lateral mass, anterior arch fracture, type 2 dens fracture, non-displaced, and a C6-7 osteophyte fracture, with some widening anteriorly and some disc protrusion on an MRI. On exam, he was neurovascularly intact. He was taken for a C6-7 ACDF and will be maintained in a hard C collar.
Good morning. First patient's a 12-year-old female, fell out of trampoline park, presented with a right elbow dislocation and medial epicondyle fracture. Patient was closed reduced and placed in a posterior splint. So the medial epicondyle, I think the alignment is pretty acceptable. I think just mobilizing her for about 3 weeks or so, letting that heal, and then giving the elbow some time to stabilize should be all that she really needs. Next patient's a 7-year-old male.
And do you know, is she a upper extremity weight bearing athlete or anything?
No, she's not.
Doesn't do like gymnastics or anything like that?
I think she does just recreational gymnastics, but she's not like competitive or anything.
Would you treat her differently, Steve?
Not necessarily. I think it's just important to recognize the patient, I think, for each of these and see what their needs are going forward, because it would enter my conversation with them in the office, just talking about a fibrous union versus a bony union with them.
Next patient's a 7-year-old male, status post fall with a right forearm fracture. The patient was neurovascularly intact, closed reduced and placed in a sugar trunk splint. Next patient's a 32-year-old female, status post MVC rollover, presented with a left shoulder fracture dislocation. Patient was closed reduced, placed in a sling. Also had a left LC1 pelvis fracture, for which will be protected weight bearing with the walker, and will be on DVT prophylaxis. Next patient's a 56-year-old male, fell through an attic, presented with a left scapula fracture. Patient was placed in a sling, was otherwise neurovascularly intact. Next patient's a 19-year-old male, presenting after an MVC with a left distal ulnar fracture, neurovascularly intact, placed in a sugar tongue splint. patient's a 71-year-old female after ground level fall with a left distal radius fracture. She was neurovascularly intact, closed reduced place in a sugar tongue splint. Thank you.
Good morning. First, we have a 2-year-old male. He fell while jumping on a trampoline. He sustained his left proximal tibia fracture. It's non-displaced. It's placed into a bivalve long leg cast. Next to a 64-year-old female, right-hand dominant. She sustained a ground level fall and had this right distal radius fracture. She presented to the office in a splint of nearly this level of deformity. We took her to the operating room for planned closed versus open reduction. We were able to get a satisfactory reduction closed, and that'll be her definitive treatment. We'll see her in the office this week. Thanks, guys.
How likely is that going to stay, Jomar?
I think that it'll at least settle some. There was some comminution dorsally, so I think we'll, when we see her in the office, I don't think it'll be exactly like this, but the chances that it'll go into a position that's unacceptable, I think are less likely for her.
And how far out was she when you took her to the operating room?
Yeah, she was 12 days, I believe, at that point, almost 2 weeks. She came to the office at 12 and we got her to the OR 4 days later on Friday, so 16.
I didn't see the X-ray, Jomar, but the proximal tibia in the kid. Is there a proximal tibia fracture in kids that you worry about? And what's the issue?
Yeah, so in kids, you worry about the quote Cozen deformity that can present later on. This one is non-displaced, but it can still happen in kids. Usually, kind of in the 16 or 18-month range is when you expect those to sort of mature, and you'll see the worst angulation. But they're usually treated conservatively and go away, or have a inconsequential amount of valgus deformity. Thanks, guys.
Good morning. First patient is a 76-year-old female who fell from ground level and sustained this right periprosthetic SU3 distal femur fracture. CT imaging was obtained, which has showed is very comminuted and impacted. She was medically optimized and taken to the operating room for a right distal femoral replacement. Next patient is a 35-year-old gentleman who fell, who sustained this right bound. Yes.
Sorry, Anna. So distal femoral replacement has gained some popularity, but what are you worried about with that?
With the DFR?
Yep.
What do I worry? I'd be worried about an infection. This is kind of like the last resort option, especially in someone who's older, and this is like a revision surgery or some sort of like periprosthetic fracture afterwards.
Yeah, agreed. It's not a minor complication when that happens, and it happens with some frequency. I'd love to hear the joints guys or the trauma guys discuss what they can do to avoid that. Any tricks to that?
I think you can certainly wait until the soft tissue, if your plan's a DFR, you can certainly wait until the soft tissues calm down before you do the case. Two, I don't want to get them moving tremendously early. Just let the wounds heal. And then there's mixed literature, but you can use the antibiotic cement, which does seem to reduce the infection rate a little bit. Unfortunately, most of these patients are really, really big. So you're fighting that BMI issue. So my usual spiel with this is I can probably fix it. If it gets infected, there's a salvage. If this gets infected, the salvage is very difficult.
Mm-hmm. All
Would
worth discussing.
Would nail plate combo something that'll let him, because the advantage of the DFR was always immediate weight bearing to mobilize these patients. The with nail plate combo that we have, there is slightly less of this decrease in weight bearing. We could let at least partial weight bear some patients, but this specific one, where if you look at the CT, I mean, it just went pretty much to the metal interface, so that you couldn't really ORF or do anything with that reliably. So DFR was the right choice for here. But yes, the DFR is anywhere between 20 and 25% complication rate. At least some of the previous literature, with most of them being wound and infection problems.
I would personally say if it goes to the tip of the prosthesis, there's still enough bone there to fix it. I've fixed them before and gotten them to heal. So I don't think that necessarily makes this the proper decision. I think it's an option to do either way in this case.
There's a sagittal that shows it goes to the condyles right there in the middle right. It's right at the condyle interface. So you'll be to the two phalanges.
Yeah, it's almost enough bone, almost always medially. You can always put a medial plate.
Yeah, intraoperatively too, the bone quality, like all of the bone behind the prosthesis was like the consistency of wet toilet paper. It was just like falling apart. It would have been really hard, I think, to reconstruct in any meaningful manner.
Anna, if this gets infected, what's the next step?
Spacer for life.
Or
I mean, you could do a fusion.
Well, you can suppress them, right?
Or yeah, you could, it depends on what the organism is, I guess. This is a 35-year-old gentleman who fell and sustained this right bimalleolar equivalent ankle fracture. He was initially closed, reduced, and splinted by the on-call resident, and he followed up for a right ankle open reduction internal fixation. The next patient is a 50-year-old female who was involved in some sort of altercation a few weeks ago, came to the emergency department with persistent pain and was found to have this left proximal humerus fracture dislocation. She unfortunately got very combative and left AMA. Next patient is a 38-year-old male who fell at work from a few steps ladder and sustained this left simple elbow dislocation posterolateral. He was neurovascularly intact. He was closed, reduced. He was stable throughout range of motion and no intra-articular fragments were seen. He was placed into a splint.
So what do you do on that shoulder when they come back in a month and they're on their psych meds and whatever else, and they're a little bit less combative?
I mean, I think you could do, like a hemiarthroplasty on it at that point. It's, I don't think that it's going to be very viable after it's been dislocated for so long. She also has a history, actually, I forgot to say, she has a history of a stroke. So she doesn't have like use of her left side, upper and lower. And so I would say, I think there's some literature on like reverses versus hemiarthroplasty. She's kind of on the younger side and is not as functioning. So I think the goal is just like pain relief and to get it in a reduced position that's not sort of agitating her muscles and nerves. So maybe a hemiarthroplasty for her.
Anna, what's not going to be viable? You said something won't be, her humeral head?
Yeah, potentially.
Why would that happen? It's going to heal. In 6 weeks, it'll all be healed, but it'll be dislocated. So
could you leave her like she is, Anna, is the question.
I'm sorry, say it again. I mean, if she's not in pain at a month, and then potentially I would just leave her because she doesn't use her arm anyways. But if she's super painful, I think you have to do something if she comes back ever.
You never have to do anything.
Fair.
It's helpful for some people, but you never have to do anything.
This is true.
Tinkoff and Lindbergh.
Last year reverse, and she'll be back with that dislocated. Then what are you going to do?
I'm sorry, what was that?
She comes back with a dislocated hemi or a dislocated reverse. Then what are you going to do? Leave her.
Yeah,
So,
probably leave her.
sounds like she's got some tough, mental issues going on. So mental health issues.
This next patient is an 85-year-old female who fell at home and sustained this right comminuted distal radius fracture. She was neurovascularly intact. Her left hand is her dominant side. She was closed, reduced, and placed into a sugar tongue splint. Next patient is a 10-year-old male.
They like
who
the
fell-
reduction over there. On the
I'm sorry.
lateral. Any critique of that reduction currently?
I think the overall alignment is okay. Her carpus is aligned with the radial shaft. She is it's impacted. So she has like the distal fragment is relatively small. And so it's impacted and kind of just caved in a little bit articularly. It was very comminuted. And, she has osteoporosis. It may not stay. So definitely watch it very closely, but I think overall the alignment is as best it's going to get closed.
It's not that it's wrong and she has 85, it's just this is not your goal reductions, right? Typically you just keep an eye on that. Looks like her volar piece is kicked out over there and the joint is not really congruent at this point.
So, Anna, I think the management's fine in the 85-year-old person, but let's say this person was 45 and you got that kind of reduction. How would you treat that person?
If she was 45, I would say I would probably indicate her for surgery and recommend surgical treatment because intra-articular, it's comminuted. And someone who's 45 is, a lot younger and functional likely. So
I would agree with you. What kind of surgery would you do?
You could try to get to just do like a volar locking plate on her. That fragment is kind of small volarly. So you may need to use some fragment specific fixation.
Yeah, I think the point on this one, like Serge was getting at, is that distal piece is very small. You actually have a sagittal split and your volar cortex is pushed volarly and rotated. So honestly, something like this, it may be one where you go volarly to fix that volar ulnar portion and try to bring that down, that little hook plate. And then something like this that's very common, you're not going to get much fixation dorsally. So this is maybe where you put like a dorsal spanning plate on it, potentially, Dr. Kirschenbaum might weigh in an external fixator with some pins here, but something to distract and then something to get that volar ulnar piece down. It's complicated.
I think you need a CT scan before you can make any of those decisions.
Yeah.
The good news is she's 85. Look at her thumb. How's her thumb doing?
Very adducted. Not so well.
I'm sure it's doing fine. Otherwise, she would have seen someone.
The next patient is a 10-year-old kid who fell from a trampoline and sustained this left Salter-Harris 2 distal tibia fracture that was non-displaced. He was placed into a long leg cast that was bivalved. Next patient is a 3-year-old girl who also fell from a trampoline and sustained this left non-displaced proximal tibial metaphyseal fracture. And she was placed into a long leg cast that was bivalved as well.
Does this mean I should return my kid's trampoline, Anna?
What do you say? Oh,
Should I return my kid's trampoline?
yeah, no more trampolines.
I thought the pediatric organization guidelines is avoid trampolines until either 5 or 7 years old. Like the actual pediatric, not orthopedic, but pediatric organization has guidelines for this.
Yeah, they do. So it's no trampolines before 5. And then if you ever sustain a fracture, they actually recommend against trampolines forever. So
I think most of the issues with trampolines are when they get 8 kids on them and jump around. It's less likely when there's 1 kid jumping on a trampoline. It happens with 1 kid, but most of these injuries are kind of unsupervised kids with like 3 or 4 kids jumping around.
Overweight 50-year-old females love to get knee dislocations and plateau fractures on trampolines.
Don't forget fracture dislocations of the ankle.
There you go. The double jump. The double jump.
Requires
old
appropriate
ankle fracture.
lubrication.
Less likely for alcohol to be involved for the pediatric fractures, though.
I gotta go to the trampoline
Well,
parks
the
with you.
parents, I'm sure, are drinking.
Thanks for the pearls. We have a first one is a 75-year-old female status with pathologic bisphosphonate subtroch fracture. It's a dreaded black line. Did a femur IM nail.
Anything else you want to do for that patient?
That she was so Dr. Gadd asked how long she was on bisphosphonates. She said she was on for about 10 years. She's originally from a foreign country. I'm struggling to remember which one it was, but yeah, she was on for like 10 years.
What else do you want to do?
Continuously?
Is that?
What else do you want to do for her? Is there anything else you want to do?
Yeah, so contralateral femur x-rays, which we obtained, and they were negative. There was no beaking or anything like that. She wasn't having any pain on the other femur. Next was
Is that more common to be unilateral or more common to be bilateral?
It's more commonly unilateral. Next is an 84-year-old female status post fall with a right hip greater troch fracture with intertroch extension. MRI was obtained showing the intertroch extension. She got a right hip intramedullary now.
Stelmach, how often are you guys over there getting MRIs for greater troch fractures to see extension? Are you doing it for every case now, or?
Seemingly every case, yeah.
Yeah, I think we're doing the same thing over here in Ohio. I think there's been kind of a, it's almost like a standard of care now. But I think, a couple of years ago, it wasn't necessarily an automatic, but I think that's something that we definitely do over here too. I was just curious if you guys are doing the same thing.
Yeah, we've been doing every greater troch's been getting one.
Do you think that? Yeah.
Go ahead. It's the availability of the MRI that was the issue, but at least Brunswick and Jersey Shore, they have at least 2 MRI machines running most of the time, so they're able to do it within a reasonable amount of time instead of waiting potentially 3 days to get the MRI.
Yeah, I guess one of the questions that we were talking about was whether or not, there's going to be edema in the greater trochanteric region that, sometimes it's hard to tell whether that extends, into a true intertroch. And I guess you have to look at the T1, but do you think some of these are getting overdiagnosed and we're nailing fractures that normally we would have just, not treated and the patient would have been fine in the past anyway?
Dr. Epstein says yes. He frequently tells us he thinks that they're overreads.
Dr. Sahabian, do you think that we're overtreating these?
It's hard to know because it only takes one that you miss and falls and breaks the hip that becomes an issue. So, it's very hard to say. And I agree with Dr. Epstein, but it's a little bit harder when you're the surgeon making the decision.
Right.
Morning. First patient's a 6-year-old female with a non-displaced left lateral condyle fracture. Was placed into a bivalve long arm cast.
So how do you follow them up in the first 6 weeks?
I would see them in a week and get repeat x-rays, overwrap the cast. And then I'd probably want to see them weekly for the next couple of weeks to make sure it's not migrating on us.
Yeah, it sounds smart. I think the first 2 weeks probably, right? It's probably worth seeing them at least at either 5 days and 10 days or 1 week and 2 weeks, because these can definitely move.
Next patient's a 12-year-old male who fell playing basketball and sustained a left Salter-Harris true distal radius fracture. He was closed reduced and placed into a sugar tongue. Is a 90-year-old male who fell getting up with his walking stick and sustained this left proximal humerus fracture. He was placed into a sling. Is a 42-year-old female who dropped a wood block on her finger and sustained this right small finger middle phalanx neck fracture. Non-displaced, she was placed into an aluminum foam splint and buddy taped. I'll have to keep a close eye on this one. There's a 26-year-old male who punched his steering wheel and sustained a right ring finger metacarpal shaft fracture. Significantly shortened, but there's no rotational deformity. He was closed, reduced, and placed into AP slab splints. We'll see him in follow-up, and if the angulation or shortening changes significantly, I think that I'd probably fix this.
So Todd,
Is
how
that-
much, I was gonna just say, how much shortening would be too much for you to justify an operative procedure?
So, I mean, there's different quoted numbers in the literature, but anywhere from 2 to 5. On this picture, I measured him at 5 millimeters short, but it's also it's not true AP because his wrist is extended back. So I'm not sure, it's pretty borderline right now. And yeah, I'm leaning towards wanting to fix him.
And what's the problem with shortening? How does that functionally impair someone?
Grip strength and changes your tendon excursion.
Yeah, I mean, I think probably more the latter, that they can't straighten their finger out all the way. I bet this guy's going to do okay. I think the only problem he's going to have is a little bump over the dorsum of his hand.
All right.
So if this is your hand, Brian, you want to leave it like this?
Yeah, I'm okay with that.
No, it's going to heal and the motion will be good, but there'll be a bump and it won't look normal. And it's pretty easy now to do a closed reduction and just put one K-wire in and you could straighten that out. So a lot of people probably wouldn't mind that 3 or 4 weeks with a K-wire.
I think that's the take-home point is it's certain people. I guess it depends on who the patient is. But yeah, I would agree with Dave. I find these pretty easy to just snap straight and put a K-wire across or intermedullary, and that works pretty damn well with very low complication rates. So not a bad idea for the right patient.
Yeah, that's what I discussed with him. I was like, it's going to heal. It's just a matter of how it heals. And he wanted to come see us in clinic and take new x-rays and see how it looks. So stay tuned.
The last one of these that I did was in a knucklehead adult hockey player who got into a fist fight on the hockey rink and broke his knuckle, broke his metacarpal right transverse mid shaft. And the problem was that he was trying to grow up and he was engaged to get married. And he was like right between being a full on knucklehead and a normal human being. So we opted for fixing it after about 7 hours of discussion. So be careful what you wander into.
Tim, you really shouldn't talk about Jeff Rasmussen like that.
Yeah, I mean, you can't be, you gotta be a little bit of a knucklehead if you're punching your steering wheel. This is a 74-year-old female who fell at home with a right proximal humerus fracture and a great toe on the other side, proximal phalanx fracture. Treating her non-operatively with a sling for now and a hard sole shoe, but this is also someone who I'd want to follow closely for that greater tuberosity.
Good morning. This is a 75-year-old female status post ground level fall who came with right femoral neck fracture. The patient was taken to the OR for right total hip arthroplasty. Yeah, so intraoperatively, when I used the calcar planer, I pushed too much and we got the calcar split. So we put the cable, the prosthesis back. Thank you.
Was that pushing too hard or was that the torque of the calcar planer?
So, yeah, maybe the torque, but I was, I was very aggressive. So I started to.
It was definitely the torque, I think.
That's, a problem that I don't have a great solution for. I mean, a lot of us try and start the planer before it hits the bone, which I think can be helpful. And you sort of, ease up on, sneak up on it, so to speak. If you start with the planer hard against the bone, I think it's far more likely to make a crack like that. But I've seen it happen both ways, and I don't have a I mean, I always worry about that.
I think it's just bad luck sometimes. If the bone that's sitting up is at the right angle and it's the right density, sometimes there's nothing you can do. I mean, you can use a rongeur, but that happened to me last week too. And yeah, I think it's just bad luck.
I think, like you said, Tim, the trick, I think, Tim, is sneaking up on it.
Morning. First patient is an 81-year-old female, sustained a trip and fall with this left intratrochanteric hip fracture. She's taken to the OR for left hip. I am now. Next was a 53-year-old unrestrained rear seat passenger involved in MVC with this left minimally displaced acetabular fracture that was actually caught on CT scan for her ER trauma workup. Posterior wall, posterior column. Taking the OR for an acetabular ORF. Next was a 55-year-old gentleman who fell from his bed. Gentleman has significant medical comorbidities, including renal and heart transplant. Renal transplant has failed. He's on daily dialysis. He's severely neuropathic. He's diabetic, among other issues. Sin his left distal femur fracture and patella ORF. That's getting better delineated fracture. Was taken to the OR for a left femur retrograde intramedullary nail with the Synthes kind of washer plate and a patella ORF.
What was the reason you fixed the pelvic fracture?
Just where the fracture line was through, oh, sorry, I didn't include the cut. It was kind of through this posterior weight-bearing dome. Well, it was non-displaced. We did discuss non-operative versus operative fracture. There's good secondary congruence. There was a little bit of displacement of that posterior wall fragment. And with this posterior column fragment, we felt just a little more comfortable. If we were going to take it to the OR to stress it, we were worried we'd displace the fracture fragment. So it was either all or nothing. So we decided to plate it to.
What can you tell us about roof arc angles, Andrew?
So I think it's once you up to about 45 degrees, the roof arc angle, you're more in weight bearing dome, you have a higher risk of displacement, I believe.
Yes, the original numbers were 45 degrees, and Mark Barris did a separate study where the posterior one, which is you have a posterior column here, anywhere within 60 degrees is probably one that's potentially unstable. And so I would agree with this case just to get it fixed.
And we did discuss, I mean, it was basically all or nothing. You're either going to take it to the operating room to fix it. You wouldn't take it to stress it. So.
And then the guy from Duke, Olson, if you look at CT scans, any fracture except for the posterior wall is no roof arc for a posterior wall. Any fracture that enters within 10 millimeters of the beginning of the acetabulum equals a roof arc of 45 degrees, and that's clearly well within that.
Oh, yeah. Next was another trampoline accident, 11-year-old female with this triplane ankle fracture. It was attempted for a closed reduction, which actually got pretty well. I didn't include the x-rays, the CAT scan showing the displacement of this medial fragment. I was taken to the OR for an ankle ORF. Thank you.
Morning. This first case, a 50-year-old male who was a pedestrian struck while on cocaine with a left trimal ankle fracture. He was 50 years old and had a heart bypass 25 years ago and has COPD, just to give an idea of his health problems. CT demonstrating a non-displaced posterior malfracture, very small, probably just an avulsion of the PITFL, and minimal impaction there at the articular surface. He was taken for an ankle RIF.
Hey, let's just go back and look at that medial, the plate on that medial mal. Jim, talk to me about that in terms of that fixation distally.
If you're not counting, so we put the two most superior screws in first, and it's functioning as a buttress plate, which is good for these supination adduction type injuries. And then we lag through the plate on that inferior screw, so that's actually lagging through the fracture. So just some added stability.
I just bring that up because I just had a case like that. It wasn't quite as high, but I was on the borderline between putting some sort of plate or going up through the bottom. Do you think there be any advantage to going up through the bottom of the malleolus, or you think you got it there just with the plate as the buttress?
Well, I think we had a combination. I mean, the fracture line was a little bit vertical, so lagging through that plate. So we have good absolute stability there, plus the buttress. So I think it's pretty stable. It's not.
So for those supination adduction ones, this is not quite as vertical as usual, but there's two studies, one by Koval, one by Eagle. You can use a plate, you can use a screw. And the strength of fixations obviously was shown to be stronger with the plate, but screws are also adequate.
Good to know. Thanks.
Did not stress them. This is actually a stress. One of these is a stress with the screw across, just to prove that it is stable. But we did not think it was necessary to stress it because of that fleck off the posterior mal. We're assuming is a ligamentous avulsion. Next case, a 32-year-old female who was also pedestrian struck. She had a right proximal tib fib fracture, as well as a left tibial plateau fracture. CT showing intra-articular involvement coming right through where the start point would be for a tibial nail. And then the other side just showing that medial depression, as well as small flex near the insertion and origin of the LCL. She was very unstable to varus stress. She was taken to a right proximal tibia RIF with a list plate and a lag screw in the tubercle. And then left tibial plateau RIF with a 2-0 plate. And we tamped up the articular surface and some bone graft.
Was she stable after the fixation? The left
We
knee
did not stress it too much, considering we just tamped up the articular surface. Her ligamentous exam in the AP plane valgus were stable. Did not stress varus too much. She's going to be in a hinged knee brace for the majority of her recovery, but with range of motion as tolerated, just to prevent varus stress.
Are these locking screws in the plate, in the medial plate?
No, they're not.
Medial plate, no.
How was that bite on those?
They're actually pretty good. Very good, actually.
You could, because they stop. Well, they're gonna have out. Synthes will have 2-4 and 2 screws that are gonna be much longer than what they usually come in. But using a 2-4 plate, the heads of the 2-7 screws will still sit, and those screws go up to 85. Some of them tap steel ones. So sometimes you could kind of use a smaller plate, lower profile, but still use slightly bigger screws that'll get you all the way across.
This was such a little fragment of bone. I don't think it even could have taken a 2-4 screw. I think the real trick was really packing it with cancellous chips underneath. You almost didn't need any fixation of how much bone we really packed in underneath that fragment.
What's the rehab, Jim, for the right side with the tibial tubercle and the plateau?
I mean, she's with the right side. She's going to be, range of motion as tolerated. We gave her a hinge knee brace. I mean, just a knee immobilizer just for a couple of days, just for the soft tissues. But she can range as tolerated. But she's going to be non-weight bearing bilaterally. It's a 95-year-old female who sustained a fall and presented to the office with a right distal radius fracture about 10 days out, completely off dorsally, loss of height, loss of inclination. So at 10 days out, the decision was made to take her for a distal radius open reduction internal fixation.
What would have happened if you just left it alone?
I think if we left this alone, the degree of malunion here would have caused a significant amount of pain, especially considering how much ulnar carpal abutment she already has. I know there's, a good amount of literature showing that in elderly people, malunions are pretty well tolerated. Most of those studies, though, they do have an additional reduction attempt. And at this point, she was, partially healing already. So we figured we'd get a better outcome if we opened it and plated it. And that was a discussion with the patient, and that was the decision that we agreed upon.
Got to be careful with volar only fixation and bone like that.
Also put her in a cast.
Yep, she was in a cast. All right, that's it.